All right, so welcome to our chemistry seminar for today. So our speaker for today is AJ Kumar from Jana Diagnostics, and he has a actually pretty interesting background. So he started with the bachelor's degree in physics from Stanford, and then he spent a couple of years doing Peace Corps in South Africa, I think it was. And so he found some real practical needs. And so then what he did is he then pursued his Ph.D. To just find very practical ways to do some medical diagnostics. And so just stuff like this is just great because we have really fancy ways we can do stuff here in the US and it costs tons and tons of money, but those are not practical for everywhere in the world. And everywhere in the world, people all over the world do have health issues that need to get managed. And so I'm actually very excited to hear about the interesting work that AJ is going to tell us about today. So I'll turn the time over to him.
Great. Thanks so much, and thank you all for the invitation to speak today. So what I want to talk about largely is the process of crossing the valley of death in doing translational technology, particularly with low-cost diagnostics. And just before I really get started, a quick disclosure is that I am an employee of JonaCare, and I'm currently consulting for Diagnostics, and I'll be talking about both of their technologies today. So if we back up and think about technology, we're often told that, technology is this great thing and has, brought benefits to people around the world. And in many ways, that's really true. Whether you're a high-powered businesswoman in New York or a housewife in rural India, the cell phone is an example of a technology that really brings benefits to lots of different people. But we can ask the question, okay, just because it brings benefit, does it actually, reduce poverty? Does it actually reduce inequality as well? And I would claim that the actual evidence is a bit more mixed. It's not the case that blind pursuit of technology always actually improves the living for everybody in the world. So what we see here is a plot made with a Gapminder showing that, if you plot all the countries in the world by the number of cell phones per 100 people on one axis and an inequality index, which is the Gini index, that's sort of a measure of how unequal a society is by measuring the gap between the top and the bottom of a country. And you plot these two together, if you, really believe and saw, just have evidence that technology was decreasing inequality, you'd expect that, the more cell phones, more technology as a proxy, the less inequality there'd be, some curve like this. And actually, if you look at this data, there's no clear trend like that. And if you exclude Europe, which are these orange dots here, and look at most of the lower middle income countries, then there's actually a trend in the other direction, which means that in some ways technology correlates with an increase in inequality. And so what I really want to stress here is that just blindly pursuing technology doesn't actually always lead to benefits for everybody equally. So what happens if we try to actually create technologies that are really aimed for the bottom of the pyramid, technologies that are aimed to reduce poverty? And one area where we've seen a lot of action in this area is global health in the last several years. So, whether you're reading the news and science news or reading journal articles, you see in the last decade there's been a lot of discussion and a lot of hype around low-cost medical diagnostics, devices, prosthetics, things like that are all supposed to create affordable health care. And when you actually go out into a lot of rural places and developing countries, with a few notable exceptions, a lot of these technologies aren't there. So why is that? Why is this the gap between what we're publishing and writing about and what's actually in the field? And of course, it's a complex problem. There's many different reasons, but one of the big reasons is what I call the valley of death. Actually, many people call this the valley of death, which is the gap between translation of an idea in academia to an actual product. And in particular, I'm going to talk about the valley of death, not just for any product, but for products for global health, which have an increased burden because they often have to be very cheap. And what the valley of death shows is if you plot the resources available to develop technology against the resources needed, and sort of look along the whole pipeline of development of a technology, that there's a mismatch. There's a point at which the resources needed to continue development outstrip the resources that are available. There's a second layer to this gap as well, sort of superimposed on top, which is that there are different sectors that really take ownership of these issues. For the most part, academia, universities tend to try to own the basic R&D and proof of concept work and publish papers, the invention side of things. And on the other hand, industry really owns the whole product development cycle, from a prototype, getting it to marketing, getting it through. And of course, this is a generalization. There are industries that do a lot of R&D and some academics that do commercialization, but this is really the large picture. And so the gap is both in terms of resources and also in terms of ownership of this middle ground. And if we really want to get things to cross this gap and see technologies that are impacting people, we're going to need to change this landscape. And so the first thing I want to tell you about is my efforts in my PhD work with Professor Whitesides at Harvard, trying to push academia into this gap, into the field and doing field testing. And at the end, I'm going to spend a little bit of time talking about, my current work in industry and Jonicare, where we're a company, trying to create products and get things to market, but we're actually, trying to think back into what are the new ideas and the new diagnostics that will be the next generation of interesting problems to solve. So if we also back up, one of the other big challenges around translation and technology is there's a gap in understanding. You've probably often heard, if you're someone that does science and technology, we build hammers, and when you have a hammer, everything looks like a nail, right? And often the problem isn't a nail, and that's not necessarily the most appropriate tool to use to solve the problem. But there's another side to this misunderstanding. And this is something that I learned by spending time in developing countries and in places like South Africa and India. When you're really immersed in a problem, you're often so busy fighting fires and dealing with the day-to-day problems that you're not able to keep up on the latest literature. You're not able to keep up with what's changing in technology. So you may have a very good idea of a good, appropriate solution for your problem, even if you don't have the money to buy it or access to it. But there may also be much better solutions available out there that you don't even know about, and so you can't even apply them. And so this mismatch goes two ways, both in technologists not necessarily knowing the problems and people dealing with the problems not knowing what's actually available out there. So one way to solve this problem is through co-creation. And this is a term that's become much more popular in the last few years. And most people talk about it as, bringing all the players to the table, having the scientists, the end users, and the clinicians all together, thinking about the problems and the kinds of solutions together, and doing this early and often throughout the process of development. And although this is definitely an improvement, it's not the whole picture. And something that I've realized is you've also got to include governments and policymakers, because they're the ones that control the funding often for a lot of these things, and they set the nationwide policies. And if you really want to make a product, you also need to think about distribution, and you need to think about manufacturing, because when we're starting to do experiments in the lab, if I'm making choices about what kind of chemicals to use, what kind of materials and processes, and if I choose my materials and processes to be things that are really difficult to manufacture, that's going to be an impediment to realizing a real product. But I can make that choice early in my research. And so when I talk about the two different projects today, this sort of framework is something that has been essential to the teams I've worked with, both for sickle cell disease and also for diabetes. And I'm not going to necessarily talk about specifically the different players in each one, but this is part of the framework that I approach these problems with. So let's begin with the first problem, which is sickle cell disease. And sickle cell disease is a genetic disease that affects the production of hemoglobin, and that in turn affects your blood cells. So a normal person with a normal alleles for hemoglobin, that'd be hemoglobin AA, has disc-like round red blood cells that are deformable. They move through your blood cells easily, your vessels easily. In sickle cell disease, that mutated hemoglobin is deformed in such a way that when it's deoxygenated, it polymerizes with other hemoglobin to lead to a deformation in the cell itself. So you get these crescent sickle-shaped cells. And these cells are not very deformable. They have that sort of crescent shape, so you can tell they can get hooked around and stuck around the body. This can lead to immense amount of pain. It can lead to an increased risk for bacterial infections, and it can lead to stroke. And if you look at a map of the geographic distribution of the sickle allele, you'll see that the majority of it's concentrated in sub-Saharan Africa and India. And these aren't places that have a huge amount of resources and infrastructure for healthcare. Now, in the US, sickle cell disease is a manageable disease. It's not curable, but people can at least live a full life. About 1 in every 100 kids born with sickle cell disease dies before the age of 5. But if you go out to lower middle income countries, you get 50 to 90% of children dying before the age of 5. And the vast majority of these are dying even though there are very simple interventions that can prevent these deaths. Things like prophylactic penicillin, hydration, parental education, and folate supplements can all make a big difference here, but you can't provide these interventions if you don't know that somebody has the disease. And the problem with that is that the state of the art for diagnosis for sickle cell disease relies on big, bulky lab equipment and centralized infrastructure. So things like high performance liquid chromatography and hemoglobin electrophoresis are the standards for doing a sickle diagnosis. And they take a few hours for results. The equipment is expensive on the tens of thousands of dollars scale, and you need fairly well-trained technicians to run and maintain them. And these just aren't available in many settings where there's the highest burden of sickle cell. So when we began thinking about this problem and thinking how do we solve it, we realized we had to sort of step back and think, what is the more fundamental property of sickle cell disease that we can sort of harness to create a new diagnostic? And we went back to the cells. The cells are sort of how the sickle cell was first identified. What else is there about these cells? They're changing shape. They're also changing density. Now, I'm talking about the mass per volume, the mass density. And in a typical person without the disease, your red blood cells have a normal distribution of densities. So that's sort of this top graph here. But in sickle cell disease, you get a significant amount of dehydration in the cell, which means you're losing water, which means the protein concentration per cell is higher, and protein is a higher density itself than water. So the density of the cell increases, and you get this very heterogeneous distribution of densities with a big tail of high density cells. Now, if we could figure out a simple way to just pick out these high density cells, then we could actually diagnose sickle cell disease. So when we were trying to think about how to do this, we went and looked back in the literature, because actually there was a lot of existing technology that we realized could do this for us. What we settled on was phase-separated systems. So aqueous two-phase systems have been known for a long time in the literature. Basically, you take a mixture of 2 different polymers in water. So in this picture, I have polyethylene glycol and polyvinyl alcohol. And when you mix them together, if you were mixing 2 salts together, you would expect just a heterogeneous mixture, complete mixing, because entropy would dominate the mixing and the molecules would all dissolve and randomly distribute. But in many cases with a polymer, what you're doing is you're actually taking monomers and you're limiting their degrees of freedom because you're connecting them together. So you're reducing the entropic sort of strength of that the different molecules. So basically what you're doing is you're reducing the entropy of mixing. And if the polymers are enthalpically unfavorable to interact with each other, what you can do is you can have a system where when you mix these together, the most favorable energy state is one with two different phases, where you basically get separation. And you have a phase that's predominantly one polymer and a phase that's predominantly a second polymer. And this is a thermodynamically stable state, and it's going to be defined by a very crisp boundary. And these have been first discovered about over 100 years ago. And over 50 years ago, they began being used very commonly for bioseparations, doing partitioning of proteins. And if you mix more than two polymers in water, you can often get more than two phases to form. You can actually get 6, 7 phases to form. And we call these aqueous multi-phase systems, or AMPs. And what you see with AMPs is that, they're self-forming. You get these layers, and the layers are stacking by density. And our contribution to the field was sort of looking at these and actually realizing that instead of just partitioning molecules, we can actually separate out objects by density in these systems. And, if you look between each phase, you basically have a step in density. And that allows you to then separate and bin objects based on their density. So these also are ideal for doing cell-based separations because your solvent is water. You can adjust the pH to be physiologically relevant, and you can adjust the tonicity to also be relevant to biology and cells. And another nice feature of these is that they're good for the point of care because they're self-forming. I don't have to sit and pipette different solutions in order and make layers. I can make the solution, mix it all up in a batch, and then pipette it into capillaries, seal them, and ship them off, and the phases form on their own. So we designed a system for sickle cell disease based on the density of those cells, based on the density of our polymers, and put it in a capillary, and this is what we've come up with. So these are all the pieces of equipment we need for the test. We have a tube. We prick a finger and load blood inside the tube, seal the tube, and then put it in a centrifuge and spin it. Now, when it's spinning, we basically have blood at the top of the tube, and during the centrifugation, the cells are more dense and the top phase will move through. And if it's normal blood with normal red blood cells, they'll stop there. They won't pass through to the bottom. But if you have those dense red blood cells from sickle cell disease, you'll get a small fraction of cells that pass all the way through and settle at the bottom of the tube. And this gives you a visual test that lets you see whether somebody has sickle cell disease or not. And so here you see, examples from someone with normal blood, someone with sickle cell trait, which is a non-disease. It's just a silent carrier for the disease. And then you see two different genetic variants of sickle cell disease, SS and SC. And even though these are different genetically, we can still identify non-disease from disease. So this looks really nice, but no science should be trusted just on pretty pictures, right? You need to see the numbers. And since not everybody's always familiar with the terminology in diagnostics, I want to just give a quick overview of some of the ways in which we talk about performance in diagnostics. And then I'll go into the results. So whenever we're doing a new diagnostic test, we have to compare our new test to some kind of standard test. And then the gold standard in this case is something like HPLC or hemoglobin electrophoresis. And if we have a sample and run it on our new test, it comes out positive. Now we run the same sample on the gold standard test. If it also comes out positive, then that's a true positive. If it came out negative, then that would be a false positive. Similarly, we can classify tests, as false negatives or true negatives if they are negative on our test. And, when we do trials, we basically get a bunch of samples, positives and negatives by gold standard, and run them with our test. And then we classify them all in this kind of a table. And finally, we can then calculate a few key performance characteristics. So the sensitivity, the diagnostic sensitivity, is also the true positive rate. It's the rate, of actual positives from the test being positive. So if I had a test, I ran my blood and it came out positive, the true positive rate tells me how sure am I that my test is really positive. Similarly, you have a specificity, which is the true negative rate. If I have a negative, how sure am I that I'm actually negative for whatever I'm testing for? And finally, we have a diagnostic accuracy, which is a combination, and it's basically, of all the things I tested, how many correct diagnoses did I make of all the diagnoses? And this gives us a way to then evaluate diagnostic tests. So here's the results from the prototype. And what I've done here is created a receiver operating characteristic curve. And this is, again, a pretty typical representation for diagnostics. And for those that don't know, in this case, if you have a continuous variable, like in the case of the sickle cell test, we have redness at the bottom of a tube, right? So you can, quantify redness. We've, create an algorithm in a computer to pick out the bottom of the tube and create a red score based on how many pixels are red. And, then we can set a threshold and say, okay, at this level of redness, classify things below it as negative, things above it as positive, and then calculate sensitivity specificity. And we can do that for several different thresholds. And for each threshold, then we can plot on this kind of, this kind of rock curve here and look at the overall performance of the diagnostic test. And, what you expect to see in these curves is a curve somewhere on this side of the 50-50 line. So this line at 45 degrees is basically the equivalent of a coin toss. It doesn't actually give you any diagnostic information. Your ideal test has a knee, basically goes straight up and over. And you can see from our test with the sickle cell test, from our initial prototype, there's pretty good results. We're looking at 90% sensitivity and very high specificity. And this was done at Harvard with collaboration with Children's Hospital and actually down at Tulane, getting samples from them as well. And so we were super excited when we got these results. We got a nice paper in PNAS, and we could have been done at that point, but we're really interested in seeing how do we actually create something that actually works and reaches people. So we had to go beyond the bench and actually get this test into the field. And that required actually solving a few additional challenges. At Harvard, we were just creating tests and putting them in a capillary tube and then running them with blood. Now we had to create tests, somehow package them so that they can be shipped across the world and then run by somebody. So we had to think about how do we train people, how do we do packaging, finding caps and seals and different things like that. How do we control for quality? We added different lines, and just thinking through the whole process was an important part of really making this work in the field. So this is what the prototype looked like, and in this box up here, you can see the equipment that we actually needed to run the test. And you might say, wait a second, you're using a car battery to power this. Isn't that a little like cheating? And the fact is, in a lot of places in Southern and East Africa, even in remote villages, you can find at least one household that has a solar panel on the roof and a car battery. And the reason is somebody wants to charge their cell phone, and other people will then come and pay a small fee to charge off of their car battery. This is a small business in a lot of villages. So there's actually car batteries available in really remote places. And that's, again, understanding the context of the design when we were designing this. So we decided to test in Zambia, partly because that's where some of the inspiration for doing this work came from in the first place. One of the doctors I was working with in Boston had done a lot of work in Zambia, and that's how we identified sickle cell disease as a problem that really needed some work. And in Zambia, we sort of were asking two questions. One is, how does the test actually work with users? Can people use it well? Do they have feedback on the design? And the second question was really, how does it perform on a larger, patient population? And so we got ready to go and really take this into reality. And whenever you try to go into reality, you're going to face a lot of real problems. So over the course of 6 months of our trial, we faced all kinds of interesting things that I would never have expected, that are things that happen outside of the science. We had the nurses in the hospital that we worked with went on strike, not once, but twice. And fortunately, the nurses on our study didn't go on strike, but because their colleagues were on strike, they ended up working extra shifts for their non-study duties. And so it's a real testament to how hardworking they were that we were able to complete the study. The second big obstacle we faced was that the Nairobi airport caught on fire. And Nairobi's in Kenya. And, we were doing the trial in Zambia. So you might ask, why is that a problem? We ran this trial over 6 months. And so we were making packs of hundreds of tests at Harvard and then shipping them over to Zambia in batches. We're shipping 5 or 6 batches over the course of the 6 months. And we had just sent one batch when this Nairobi airport caught on fire, which ends up being a regional hub for most of East and Southern Africa. So our tests ended up sitting on the tarmac in Heathrow Airport for about a week, longer than it really should have, before it reached the destination. And finally, we ended up having problems with our gold standard equipment. The gels in our gel electrophoresis were coming out a little bit crooked, which made them difficult to interpret. And it took a while to get service out because we had to get service from South Africa to come out to Zambia to service the equipment. And, all that slowed down the trial, but it also illustrated sort of why we needed to be doing the work that we were doing in the first place, because this kind of expensive equipment is not really feasible for the infrastructure there. So once we got through all of that, we got our results. This is what they looked like for our version 1.0 of the sickle cell test. And you see, again, we put a ROC curve. Here we had visual people reading this test by eye, and we had them visually quantify the redness in bins of different types of amounts of redness. And we're no longer this perfect looking ROC curve. We have, we're somewhere between a coin flip and perfect. And so the biggest thing we took a hit on was specificity. And evaluating what actually happened, we realized that there's a lot of things going on, especially in terms of packaging, stability, and storage, that were potentially affecting our test. So again, this is a place where a lot of academics will stop, if they've even went this far, because that's sort of outside of our domain of expertise. Instead, what we did is we decided, this is a little bit beyond what we know how to do. So we're going to bring in partners. And so this is where, it's really important to think about having everybody at the table. We brought in Diagnostics, which is a company that does a lot of development for diagnostics for emerging markets. And we brought in Drummond Scientific, which is a manufacturer that produces a lot of different types of precision liquid handling systems, and that includes capillary tubes. And since we were having issues with stability and storage in our capillary tubes, they have ended up being, fantastic partners in this. And over the last year, we worked together to sort of revamp the design and identify issues. And this is the sort of version 2.0 of our device. Again, it's very simple. It's just a glass capillary tube. And this time it's sealed on one end with glass and open on one end. And now we've made a 2-part design. So there's a second tube, which is a thin tube for collection. And this tube is coated with an anticoagulant. So we have what we call the ampule, which is already preloaded with the amp solution. And we just cap the end. And then we ship these two together. And, one of the biggest things we did is we moved to glass from plastic. And what we've seen is that has made a huge difference. And so what we've done is we've tried to really simulate as close to Zambia as possible, packaging, making these ahead of time. And we've shipped them to South Carolina and actually run them and had, again, not us, but some naive readers who we then, have been trained, but don't really know what the experiments are. So they really don't, not biased when they're reading it, and had them read the test, sort of very similar to Zambia. And what we found with our version 2.0 is that our performance is much better than it was in Zambia. And that's actually even a little bit better than it was in our initial Harvard prototype. And the other thing about these more recent tests is we've been testing it on finger stick blood. This is designed to be a point of care test. You want to do it directly from a small finger prick. All the previous studies were done with venous blood, which is a little bit easier to get in a research setting, which is why it was done that way for the initial work. But this is much more realistic, and we're getting great performance. And you can see again from the raw curve, we're almost perfect. So we're very excited about this. This is the most recent results, and moving forward with the commercialization of this and hoping to really move this forward. We have plans in early 2016 to go back to Zambia and test this new design and see if these parameters actually hold up to the real stress of that kind of a trial again. So what we've done with sickle cell is we've begun crossing this valley. We started off with a very academic paper doing aqueous multi-phase systems for density-based separations. Then we did a little bit more applied science, looking at a proof of principle of a sickle cell diagnostic. And then we pushed out into that territory that's a little bit less familiar, actually designing, doing a clinical evaluation in a, African country. And we went to the stage where we're at this sort of handoff point, where we have a sort of a prototype and working very closely with industry to hand this off and have them now continue most of the development moving forward. So that's one strategy that I've taken to try to help get technologies across this gap. And one of the keys to doing that was to really try to reduce the resources needed. The test itself, as you can see, is very simple. The concept is just sinking and floating. And the equipment needed is quite cheap and simple as well, a small centrifuge and capillary tubes. And by decreasing the amount of resources needed, we could go farther on the budget that we had. So that's how we went from academia. And now in the next couple of minutes, I just want to touch on my current work in industry. And here we're shifting to a different problem, which is diabetes. Now in diabetes, there's a gap both in diagnosis and in treatment. So it's estimated that there's about 400 million diabetics globally. And the first gap is in diagnosis. Only about half are actually diagnosed as diabetics. And then the second gap is in therapy. Even smaller percentage are actually meeting their therapy goals. And this, leads to a huge amount of cost on healthcare systems around the world. And, the other big issue with diabetes is it's not just a rich world problem anymore. 80% of diabetes burden is now in lower and middle income countries. In particular, places like India have some of the highest diabetes burden in the world. So at Jonicare, we're trying to address this problem and address both these gaps by sort of rethinking how we do diabetes care. And we're doing that by creating a combination of affordable diagnostics and pairing those with an intervention, which is personalized digital coaching, because diabetes really is a lifestyle disease. And together we get data from those two that then feed into predictive analytics that can then help both patients and physicians better manage the disease and hopefully lead to better health outcomes. And Jonicare was started by a Harvard Business School student and an MIT engineering student in Boston, but quickly after starting the company, they moved directly to India because, they wanted to work on the issues around diabetes. And like I said, 80% of the burden is in lower middle income countries. And if you want to solve that problem, you really need to be where the problem is. And that sort of allowed us to have this really strong methodology of co-creation, because we're working with hospitals and clinics in India every day. And part of our solution is technical and science. It's we've created a small hardware device that plugs into a phone that can read colorimetric test strips and quantify them. And we've also created an array of dry chemistry strips to do blood tests. Things like glucose, lipids, hemoglobin, and creatinine. And the real key one is hemoglobin A1C, which is how people now diagnose diabetes. And we have one of the first really low cost and really portable HbA1c diagnostics. And one of my goals and my projects as the scientific director at JonaCare is we've begun working on the next generation of blood tests, to go into this device that will help people really proactively manage their diabetes and the comorbidities like heart disease. But it's, again, more than just diagnostics. It's about what we do with that information. So on the other side, we have the Habits program. It's a personalized diabetes management program that combines feedback from our blood measurement device with a curriculum that's based on the NIH-tested diabetes prevention program and look-ahead trials. And that's like a 12 to 16 week education trial that showed that people in coaching and mentorship support and education about their diabetes could really take advantage of those and change their lifestyle, change their eating and activity, and decrease weight and decrease their risks. So we combine those two and then also add in coaching support. So we have a system of diabetes educators that can call in once a week to people on the program. And that provides that sort of personal touch to help motivate people to actually do what they're supposed to be doing on the program. And we've been doing this. We have about 3,000 people using this on a regular basis in India already. And we're seeing some initial results. So this is all very encouraging. And, one of the keys, like I said, in both the sickle cell test and diabetes is that we're really trying to work with everybody in the chain as much as possible. In Zambia, working, down to the rural clinics, to the hospitals, Ministry of Health, and in India, going out into the field, working with hospitals, working with patients to really understand what the needs are and how we can solve them together. So, one of the things that I learned in the different times I spent in different countries are a lot of different proverbs. And one proverb you might have heard is that if you want to go fast, you go alone. But if you want to go far, you go together. And when we're really trying to solve this problem of global health, we have to be in it for the long haul. And so we really have to work with everybody to make a collective solution. And with that, I want to thank all the people that were part of this. There's a huge team of people at Harvard, at JonaCare, the different companies I mentioned, and our clinical collaborators, as well as funders who have made this work possible. And finally, I want to thank you for all of your attention and thank Emory University for inviting me to speak.
So we will take some questions. Again, remember to say your name before you ask your question. We have one over here. I'll come here first.
Hello, my name is Helen Yu. And so if I remember correctly, you said that the typical method of sickle cell diagnosis is takes a lot of time and is rather costly.
Mm-hmm.
And so now that we have this method, is it used in the US as well? Or I was just wondering what the point of having the other method is.
Right.
If this way is a lot more efficient and cost effective.
Yeah, so there's a few things. With something like hemoglobin electrophoresis or HPLC, the sensitivity is really high, in terms of not the diagnostic sensitivity, but the ability to pick out sickle hemoglobin is really high, which is really important for newborn screening. So in newborns, you don't necessarily have sickle cells yet because you have what they call fetal hemoglobin. It's a early form of hemoglobin that young kids have, and they have until they're about 6 months old. And they only have a little bit of hemoglobin S or A. So you need to be able to pick out a really small amount. And our tests may not be able to do that, but these other things will. The other reason why in the US we still would be using these kinds of things is that they're expensive when you're doing it sort of one-off for a small hospital. But when you have, like we have in the US, we have a fairly well refined medical industry and infrastructure. So, for example, here in Boston, there's a newborn screening center that screens blood spots from babies born in about 3 or 4 states: Massachusetts, New Hampshire, Vermont, and some of Connecticut. And all the babies born, all their blood is shipped there. And so when you do it in that bulk, then the price comes down. So it's actually then becomes more affordable.
Hi, my name is Emery Dent. Quick question. Does the INA platform mobile blood monitoring system require some sort of internet connection?
No, it doesn't actually. So, it runs off of the mobile phone. You can, once you have the app installed, it can run independently of the internet, and it can store those values so that, when you're out of a service area, you can do the test. And then once you get back into a service area, you can send it back over the network.
Hi, my name is Allie, and I was wondering, are there any programs that support developing medical infrastructure in these third world countries?
So yeah, there are a few. So do you know there's a group called Partners in Health, and there's a group called Last Mile Health. And actually, during the whole Ebola epidemic that happened recently, they spent a lot of time trying to actually really say, like, look, what was going on with Ebola is that it's not an epidemic that needs new technologies necessarily. It just needs the same old infrastructure that we have everywhere else. In the U.S., when we got an Ebola case, we were able to contain it immediately. But in Sierra Leone, when they had it, it spread out like crazy. So those organizations are doing a lot to try to help build up infrastructure in those countries to deal with things like Ebola and other health problems.
Hi, my name's Iris. I don't know if you touched base on this, but what interested you in joining the Peace Corps after school?
Yeah, so for me, it was actually knowing people that had done the Peace Corps when I was a kid, and the stories they used to tell and the way they used to think about the world and things. To me, it was different. They had a different perspective. They had a different way about them, and I wanted to understand that. And I also wanted to kind of understand the world better. I felt like, I had grown up pretty much my whole life in the U.S., and I'd visited a few other countries, but had an idea that of the differences, but didn't really know what it was to live those and being part of those. And so that was part of why I went in there.
Hi, my name is Emily. I'm wondering, the test that you guys created for sickle cell, how long is it good for? From like the time it's created, at what point does the test become bad and not work anymore?
Right. So that's actually a really important question. That's something that, is important when you're developing things like this to think about. We're currently still evaluating exactly how long it'll last for, from when you make it and package it to when you can run it. Our target is, the best case is 2 years shelf life that we're aiming for. If we get 1 year shelf life, we'll settle for that. We're kind of in this, the stage where with the new prototype, we're evaluating what the shelf life actually is at this point. We have shown that 1 month seems to be okay, at least. So we're building up from there. But that's the problem with doing those kind of things. You need to sit and wait for 12 months to really know if it works or not.
Hi, my name is Adrian, and I was wondering, what interests you in sickle cell disease, just specifically?
Yeah, so it was actually an interesting way that we got involved in sickle cell. I actually began my PhD work on malaria. We were using the same AMP system and trying to separate out, blood cells that were infected with malaria based on density. And for a variety of different reasons, that ended up not necessarily working. Probably it was the wrong problem to be solving. So I had all this information about density separations in cells, and I was at a sort of a conference or symposium at the medical school down here, and ran into this doctor, Tom Stossel, and he had spent a lot of his career working in Zambia, and we got to talking, and he was the one that when I talked about my work in malaria and some of the roadblocks, he was like, "Why aren't you doing sickle cell disease instead?" And so that's sort of the conversation, and that was sort of really serendipitous in many ways. But once you find that right problem, and that's, I think, one of the real points is to just talk to a lot of people, because you never know where the next good problem and good solution are going to come from.
Hello, my name's Noah, and this is kind of two questions, but they're really related to one another. The first question would be, how many people were working together in this group planning this whole project? And then the question right after that would be, the project seemed initially focused on making the technology to test for those tests, but then towards the end, it seemed like you were also planning on further uses for that test. So like after they test it, they would have this plan that they would follow. So I was wondering whether or not you had planned that before the project started or during the project.
Right. So the answer is a little bit different for both the different sort of tests. For the sickle cell test, it began with just me and sort of Tom and another doctor here, and there was a number of people that came in and out at different points in the project, but I think there was usually about 3 or 4 core team members at any given point in time. But all told, it's probably about over 20 people that have been involved in the sickle cell project, and that was before really. Then now that we have the companies involved, there's another dozen people involved in the sickle cell test. And in the diabetes stuff we're working on, the co-founders, kind of started with about a team of about 4 people, about 3 years ago on that. And the team is currently 15. But we also have partners at hospitals. So if you include those, it's probably over 20 people working on this together in some way. And now in both cases, we started off with the aim for diagnostics. But with a lot of diagnostics, you only want to really make a diagnostic so there's something you can do about it. With sickle cell, we're trying to connect with ministers of health and people like that so that they will be able to connect people with services and service centers for things like that. With the diabetes, the problem is that there's so much diabetes that there aren't enough doctors to connect people to. So that's why with Jonicare, we decided to try to tackle that problem as well. We're like, well, if we're going to diagnose them, we need to actually give them something they can actually use to deal with the problems that they have. And actually, the thing about software is that it's a lot faster to develop. So we've been the HABITS program has been launched a little bit faster than our diagnostics. So we've been trying that in India for a while now, and we're just sort of launching the diagnostic side of it.
Hello, my name is Seth, and I was just wondering if there were other diseases that you guys were starting to work on, or if there's a particular disease that you guys think would be very important and vital to work on next.
Yeah, so with the sickle cell work, with the stuff we're using the density-based technology, we've done some initial work, and actually we're in like a fairly advanced side of a paper doing iron deficiency anemia, because there's a lot of tests out there to just detect anemia, but not a lot that actually can differentiate between iron deficiency anemia and anemia from some other cause. And that's important because if you have iron deficiency, then you can treat that very easily with iron supplements, but other ones need other attention. So that's one with the density one. With diabetes diagnostics, definitely we're working on other things, and that's sort of my main work right now. And I've been, working with different doctors in Boston, identifying a few different biomarkers some specifically for glycemic control, control of people's sugar, to measure that better than you can do with just hemoglobin A1C or the glucose test. And the other tests are actually looking at heart disease, because especially people that are at risk for diabetes are often at risk for cardiovascular disease. So we're looking for we're working on diagnostics for early monitoring of heart disease as well.
Hi, my name's Gabriel. I was wondering, what advice would you give those of us who are not business inclined? How do we take a good idea and turn that into reality? What's the first step we should take?
So, I think it's important, to figure out if you want to be a part of that solution going to reality the whole way. If you want to basically stay with the idea and go with it in a company, or if you want to hand it off to someone else, if you want to just be creating ideas more just academic and finding partners that'll take it on. And, if, actually in either case, one of the most important things is to actually just go out there and try to meet people that are actually the ones taking stuff out there and commercializing it. So if you're interested in diagnostics, trying to get out there and meet people in the diagnostics industry. I really benefited during my Ph.D. from having mentors who were, like maybe 2 or 3 years older than me to up to 10 years older than me, who were basically farther in their career, both in the academic side as professors and some that were all in the industry side, both in the business side, but also in the science side of a business. And just finding those mentors and just talking to people is really important.
I have a question too. This is Desmond.
Yeah.
So the AMPs, are you looking at non-medical applications of those multi-phase systems?
So I am personally not doing as much on that. We have done some work in the past. We actually have a paper published separating nanoparticles in those AMP systems. And I know that we have the IP on it, and we've actually been in talks with a couple different companies. Hopefully 1 or 2 will license it for some non-medical applications as well.
Okay. All right. Looks like we are out of questions here. So we want to thank you very much again for a really interesting seminar.
Thank you all.
Oh, no, he's way after my time.